Thank you very much. Good evening, everybody. This is my conflict of interest. I am the author, first author of the Urticaria Angioedema Practice Parameters for the Joint Task Force. I've done clinical trials for a number of companies, and I am a speaker, and I'm also involved in organizational activities. The objectives today are four. We will define angioedema and the mechanisms of different angioedema subtypes. We'll discuss the evaluation and diagnosis of angioedema, determine the best treatment options for patients with angioedema, and discuss considerations for dental professionals who may have patients with angioedema. So let's begin by defining what angioedema is. It's characterized by swelling of the mucosa or submucosa and or the subcutaneous tissue of the skin. You can see in this picture one with significant swelling of her face, her eyes, her lips, and this is quite prominent. But as you can see from this picture, there are many different presentations of angioedema, and not all of them have the same cause. And you can see that many different underlying causes can lead to swelling. So it's important for the health professional to recognize this. Physical examination doesn't always differentiate the types of angioedema that patients present with. In terms of prevalence of angioedema with or without urticaria, we see a lot of hives, and about 40 to 50% of patients have hives isolated by themselves, but about 40 to 50% of patients also have hives associated with deeper tissue swelling, angioedema, and up to 10 to 20% of patients have isolated angioedema. And we try to identify what the causes are of angioedema without urticaria. This is one clinical survey which looked at 776 patients. They found that a significant number of these patients, again, this is subject to skewed bias based on the population center, had hereditary angioedema, but a number of these patients had unknown causes for their angioedema. And when we looked at differences between unknown causes, some of this was considered histaminergic, others non-histaminergic, and so forth. So what I want to do this evening and the remainder of this discussion is talk about specific causes of angioedema in the context of a series of case studies. So when we look at the types of angioedema, idiopathic is probably one of the more common causes because we don't find a cause, and it's often associated with urticaria. However, there are IgE-mediated causes such as foods, drugs, insect stings, and infections, and non-IgE, which we also refer to as non-bradykinin-mediated types of angioedema, which would refer to non-steroidal anti-inflammatory drugs, aspirin, systemic diseases such as thyroid disease, autoimmune diseases, or underlying malignancies. Now, hereditary angioedema is a rare autosomal dominant disease which affects about 6,000 people in the United States, where patients have a deficiency of C1 esterase inhibitor, or they have the C1 esterase inhibitor, but it doesn't function correctly. There are also other types where patients have normal complement levels but have, which we refer to as type 3, that may have this condition as well, but this is less well defined. There are patients who have acquired angioedema, which is due to either an underlying lymphoproliferative disease, a malignancy, or secondary to an autoantibody formed in direct response to C1 inhibitors, so it blocks C1 inhibitors' activity. Other types of causes like vibratory, delayed pressure, cold, these are called physical stimuli that can cause angioedema. And then certain medications, exogenous forms such as ACE inhibitors, like lisinopril being the most common, as well as angiotensin receptor blockers can be associated with angioedema. Although a number of medications can be associated with angioedema, ACE inhibitors seem to be the most prevalent. In terms of pathophysiology, in terms of bradykinin-mediated angioedema, which we also refer to as non-histaminergic angioedema, meaning it's not mediated by histamine, whereas the histaminergic is. Histamine, as you may know, is a mediator released by mast cells and basophils. We don't think that non-histaminergic angioedema is mediated through histamine release from mast cells, there's some type of stimulus that turns on the attack, and again, patients have a increased production of bradykinin as a result of unimpeded breakdown of high molecular weight kininogen to form bradykinin. This causes stimulation of bradykinin 2 receptors that results in vascular permeability and angioedema. Now, in histaminergic angioedema, there's some inciting agent, which is an allergen. It could be a food, it could be a drug, it could be an aeroallergen that where patients have developed specific Ig antibodies to this protein, and it binds to mast cells. It attaches to receptors on mast cells and basophils, and upon re-exposure to this antigen, there's activation of these cells and release of histamine, as well as other bioactive mediators. And this histamine binds to H1 receptors on blood vessels, and that can also cause vascular permeability and angioedema. So it's up to us to differentiate what's going on with these patients so that we can treat them properly and prevent these episodes from occurring. So what are the clinical characteristics of angioedema subtypes? Well, the bradykinin mediated, that's not mediated by immunoglobulin E, which is a specific IgE antibody that's produced in patients who are what we refer to as having allergies. It's not usually associated with urticaria. The attacks may last up to 5 days. It's generally unresponsive to antihistamines or corticosteroids. The onset occurs in childhood or young adulthood, and it worsens at puberty. Whereas the histaminergic or histamine-mediated angioedema is oftentimes mediated by IgE antibodies. It's usually associated with urticaria. The swelling normally subsides within 24 to 48 hours, and it is very responsive to antihistamines and corticosteroids. So as I mentioned, we're going to talk about a number of cases that will illustrate the differences between these types of angioedema. So case presentation 1 is a 30-year-old male who was while gardening was stung by a honeybee. He immediately started swelling at the site of the sting, and the stinger was removed. Within 20 minutes, developed diffuse hives, lip swelling, chest tightness, difficulty swallowing, and dizziness. He called 911. Epinephrine was administered along with diphenhydramine, which is Benadryl, intramuscularly on the way to the emergency department. And in the emergency department, he received more IV corticosteroids. His symptoms resolved within 30 minutes, but several hours later in the emergency department, the patient had recurrence of hives and lip swelling. Epinephrine intramuscularly was re-administered. The symptoms resolved, and the patient was discharged home after 23-hour observation and referred to an allergist for further investigation. You can see pictorially the series of events that occurred in this individual. Now we think about anaphylaxis. In this case, it was insects, and insects are thought to occur in about cause anaphylaxis in about 11% of cases. Foods are probably the most common. Up to 30%, almost 30% of patients who present with anaphylaxis, you can identify a specific food. More common in children than adults, and peanut is the #1 cause. Medications are also very common and more common in adults. A number of other causes which are not as clearly defined, about 7%, but a significant percentage of these patients who present with anaphylactic-like symptoms, we don't identify a cause. Now, in a survey of fatal anaphylaxis in the United Kingdom, they found that medications were the most common, followed by foods, insect stings, and then there was a number of other causes that were much less common. Epinephrine, however, was only given for 62% of fatal reactions, but to only 14% of patients before arrest. So in this survey, it indicates that epinephrine is not given early on in these episodes of anaphylaxis. So in a patient who presents with more than one organ system involvement, always err on the side of commission than omission. Epinephrine should be administered. And this, again, I think a lot of people don't give epinephrine because they're concerned about side effects and such. But in general, in these situations, the safety outweighs the risks of not treating these patients. Another important point that's illustrated by this case is biphasic presentation. 1 to 23% of anaphylactic episodes might have a biphasic presentation, and the late phase begins 1 to 2 hours after the exposure. So in the initial exposure, there's a rapid onset of symptoms within 30 to 60 minutes. Patients given treatment, and then there's a period of time where they actually are not having trouble, but then they can have these delayed responses. And this is what was referred to as this biphasic response. In these situations, epinephrine is less likely to lead to a biphasic response if it's used in the initial treatment phase. Corticosteroids typically do not prevent this biphasic response. So in terms of the acute treatment of allergic angioedema, this is a histamine-mediated response. It is recommended to administer epinephrine, either IM or sub-Q. We recommend IM at a concentration of 1 to 1,000 for anaphylaxis, especially when there's respiratory stress or angioedema. And these are the doses for adults, up to 0.2 to 0.5 ml. Normally the dose is 0.3 cc's. In children, it's 0.01 ml per kilogram. One may need a second dose for a late phase response. Antihistamines are effective in most cases, but they're not the primary treatment for histamine-mediated angioedema or anaphylaxis. Now, the problem in the emergency room, it's very difficult for doctors to differentiate the angioedema from anaphylaxis because they're presenting acutely, and so again, the patients say, I've got angioedema, I might have some hives, I might have some respiratory, some tightening. You can't always tell if it's because they're anxious, but these are patients who you have to take serious and treat aggressively. Corticosteroids certainly can help for late phase, for treatment, adjunctive treatment, but they don't always prevent the late phase response, as I've already mentioned. So that's a classic case of acute angioedema. In that case, the patient also had hives and had been stung by an insect and was being treated as anaphylaxis. As I mentioned, for an acute episode like this, it can be very difficult to differentiate angioedema, isolate angioedema from anaphylaxis. Now, once these patients have recurring episodes over several weeks and longer than 6 weeks, that's when we start to call it chronic. Then it is easier to differentiate from anaphylaxis. Now, the second case is a patient, a 46-year-old female, who presents the emergency department with angioedema of the lips and tongue that had been present when she awoke. She had 2 other episodes in the past 3 to 4 weeks, which were milder and resolved on their own after 2 to 3 hours without medication. She had no associated urticaria, and there was no known triggers for the onset of swelling. Her physical exam and her history and physical exam revealed she had a history of hypertension, gastroesophageal reflux disease, high cholesterol, but no history of allergies or asthma. She was taking lisinopril 10 milligrams a day for her blood pressure for the past 6 months. She was on omeprazole for a reflux, and she was taking simvastatin for cholesterol. She had no tobacco alcohol use. She was a registered nurse. Her review of systems was unremarkable. On physical exam, she had tongue swelling, but good air movement, and her upper and lower lips were also moderately swollen. Her labs, including a CBC, a liver profile, renal profiles, were all normal. So the differential diagnosis for this woman is ACE-induced angioedema. One could also consider hereditary or acquired angioedema or idiopathic angioedema. However, in this case, given the fact of her, the age, her history, the age of onset, it's most likely ACE-induced angioedema. And these are pictures of patients who present to the emergency room with ACE-induced angioedema. It can affect different parts of the body, but typically targets lips and tongue. And again, the tongue is what gets so big, it can occlude the posterior pharynx and cause asphyxia and death if these patients don't have a secured airway. The epidemiology of ACE-induced angioedema is anywhere from 3.5 to 6.5%. In the emergency department, it's estimated up to 30 to 46% of all angioedema cases are due to ACE-induced angioedema. The risk is highest in the first 3 months, but can occur even years later while taking these medications. Typically, as I mentioned, it affects the face and oral cavity in 57% of the cases, the base and tongue and soft palate 26%, and oral pharynx at 17%. GI symptoms can occur, but they're not common, and patients, when you screen them, unlike other types of angioedema, that they have normal C4 levels, so they don't have hereditary or acquired angioedema, which I'll talk about in a little bit later in this discussion. The morbidity and mortality can range from is approximately 0.1%, but intubation or airway surgery ranges from 7 to 14%. So this has significant connotations if it's not recognized and it's not treated properly. There have been several studies that have looked at whether or not, given the fact that we think that this is bradykinin mediated, we use medications that have been approved for other bradykinin mediated forms of angioedema to see if it would also be effective in ACE-induced angioedema. This one study published in New England Journal of Medicine in 2015 by Murat Bas showed that icatibant, which is a bradykinin 2 receptor blocker, so it actually blocks the receptor so bradykinin can't bind to it, showed there was some benefit in terms of treating these patients with icatibant. However, studies that have been done subsequently, including a study we did not show statistically significant benefit using these agents. In this case, we used Kalbitor, which is a kallikrein inhibitor. It was not effective. And subsequently, there have been many multi-center ecallantine studies, which is a kallikrein inhibitor, a multi-center icatibant study, which is what Murat Bas used in his study, which is a bradykinin 2 receptor blocker, and then another study which also looked at bradykinin 2 receptor. All of these studies were negative. So it's not clear that this is purely a bradykinin-mediated condition. In fact, one can see that there are many other enzymes, including dipeptidyl peptidase, that are important for the degradation of bradykinin as well as substance P. And it's thought that because of that, it's not purely due to defects in the pathways that are important, they're responsible for producing bradykinin. That's why these other therapies that are targeted towards bradykinin production were not effective. So when we see angioedema in the emergency department, this is an algorithm which was published for the it was published in Academic Emergency Medicine, and it goes through the evaluation. So a patient who presents with angioedema in the emergency room should have their airways assessed. They should be triaged. Is it anaphylaxis? Is it HAE? Is it some other condition? Again, treatment with conventional therapies if it's not effective. Then one needs to think about other causes. One has to think about ACE-induced angioedema, these other bradykinin-mediated angioedemas versus a more difficult refractory form of histaminergic angioedema. One thing that's used in the emergency room is something called the issue classification, which helps stage the severity of angioedema. Stage 1 being a facial rash, facial and lip edema. This is a low risk for airway intervention. These patients can often be observed for short periods of time and discharged home. Stage 2, these patients have soft palate edema. Again, a low risk for airway intervention. Again, can oftentimes be discharged home. But a patient has stage 3, it's tongue edema. They may have anterior lateral lingual edema, which poses low risk, but also they might have diffuse lingual edema, which poses greater risk, and these patients should be admitted to the intensive care unit. And then stage 4, which is very severe, where they have laryngeal edema, and 25% of these cases require intervention. So this is, and they end up in the ICU. So this is a classification system that's used by ED docs when they're looking at these patients in the emergency room. Again, these patients have large tongues, and if alarming symptoms of airway obstruction occur, stridor, dyspnea, signs of respiratory arrest, they should be intubated. The acute treatment of ACE-induced angioedema is discontinuation of the ACE inhibitor. Even after discontinuation, however, these patients can have recurrent angioedema several weeks or months later, so it's important to recognize that. One can administer epinephrine for respiratory distress, but it's not effective for the angioedema, nor are antihistamines and corticosteroids in many of these cases. There have been patients who have been administered fresh frozen plasma, which has been reported to be effective. Other cases have received C1 esterase inhibitor, which is used in hereditary angioedema, that have been shown to be effective, and also catapult and ecallantide. But I've already showed you in all our studies, in all the studies, these agents have not been effective. So at this point, discontinuation Monitoring these patients' airway, intubating them, securing an airway is probably the best treatment options presently, especially since emergency rooms will not have these other medications readily available because they are very expensive and not kept on most formularies. So I'd like to now talk about presentation 3, which is the 30-year-old female who presents with a history of recurrent swelling of the face, neck, hands, and feet, abdomen with occasional throat swelling sensation. She notices symptoms worse with menses, stress, and after trauma. They're associated with a rash preceding the swelling episodes. Her mother, aunt, and 2 sisters have similar symptoms. At age 19, she had an emergency appendectomy for an acute abdomen. This is her before and after the angioedema episode. You can see she has a pretty face, and afterwards she's got swelling of her face and lips. Interestingly, she has this characteristic rash, which is seen before many of these cases. Again, this is a case of hereditary angioedema, and many patients may present with this rash, which some people mistakenly think is hives, but it's not itchy, and it doesn't come and go, it just stays, and it's called erythema marginatum. Not everybody has it, but it is a prodrome, something that occurs, and patients can tell when they get this rash, they know they're going to have an attack. So what are the clinical features of hereditary angioedema? Again, it's a rare autosomal disease that affects maybe in 1 in 50,000 people, so there's a large likelihood that you'll never see this case. Although if you're a dentist taking care of a patient that I see with HAE, then you really need to be talking to me about what we want to do with this patient before we start doing invasive procedures. These patients have severe angioedema without hives. Their onset typically varies between studies, anywhere from 5 to 11 years of age. Again, swelling can occur anywhere in the body, typically mouth, tongue, airways, arms, legs, stomach, genitourinary tract. The peripheral extremities and abdomen are the most common places where swelling occurs. It may be mistaken for, again, acute abdomens where patients have abdominal swelling and pain is mistaken for rupture of the appendix. We have several patients with this condition who present with us having had their appendix removed already, or gallbladders. As I mentioned, patients may have prodromal symptoms where they have the characteristic rash, they have tingling sensation, they feel nauseated, they know something's happening. And again, patients may also have triggers. It might be mechanical, surgical triggers, invasive triggers. So again, a lot of dental procedures are something that can occur. Stress and so forth. Hormones are a big trigger. These people should not be on, the women should not be on estrogen supplements. It's a major trigger. Certainly they should not be on ACE inhibitors. That's an absolute contraindication. When they do have an attack, it lasts several days. Attacks usually get worse over 24 hours and improve over 2 to 4 days without treatment. They are not responsive to conventional therapies like antihistamines, corticosteroids, or epinephrine. This is just a slide from Conrad Bork's study that showed the average onset looks around anywhere from 10 to 13 years of age. However, studies we've done showed that the age of onset can be earlier at 5 to 6 years of age. Many patients, I would say most patients, have prodrome symptoms, and these are just listing the different types of prodromes. They can have unusual fatigue. You mentioned the rash. They have muscle aches. They have nausea, joint pain, cramping, and so forth. So in one survey of 46 HAE patients, 87% of patients reported a prodromal symptom, but this will vary between patient populations. I mentioned the triggers are not always predictable, and not everybody has known triggers. It may vary between families as well as within families, but stress, physical trauma, infection, menstruation, medical and dental procedures are very common triggers. I mentioned the medicines that worsen it, HAE, oral contraceptives with estrogen, or other forms of hormone replacement therapy, ACE inhibitors. But again, 60% of attacks have unidentifiable triggers. This is just sites of location. Extremities, gastrointestinal regions are the most common, but head, neck, and genital areas can also occur. This is just showing pictures of a woman in the first panel where she has pain, and you can see what happens to her abdominal swelling. She develops significant abdominal swelling, and that basically the slide here shows a scope where she has almost total occlusion of her abdominal lumen, and here you see spiculations on a flat film, which are characteristic radiation findings. And when they've opened her up, look what happened, is huge abdominal swelling. Again, this would not be indicated in these individuals. Now, sometimes these patients can have torsion and have acute abdomens, and that's even though you give them treatment, so that's something to be looked out for as well. The upper airway, though, is the most ominous area where patients can have trouble, and you can see that this is what we don't want to see, because this is what leads to asphyxiation and death. Up to 50% of patients will have a laryngeal attack at some time in their life, and about 18% require intubation. And even the first attack can be laryngeal, and this is the most common cause of death. These patients with C1 esterase inhibitor deficiency have deficiencies in chromosome 11 in their serpine gene. This is the gene that encodes C1 esterase, and there's many places along this gene region where mutations can occur. Now, 75% of patients have genetic mutations that are passed down from one generation to the next, but 25% of cases have spontaneous mutations and they don't have a family history. So even though they don't have a sibling or a mother or father, they potentially still could have C1 esterase inhibitor deficiency. C1 inhibitor is a very important regulator of a number of different pathways, including the complement system, which is an innate immune system that protects us against infection and other autoimmune disorders. It also is important in regulating clotting, but in the fibrinolytic pathway. But really where the action is in the contact system, where it regulates the production, the breakdown of high molecular weight kininogen to form bradykinin. So it has other areas of activity which are important, but that's why targeting C1 esterase inhibitor or kallikrein or bradykinin are the most important areas to prevent these attacks. In terms of diagnosis, there are many different profiles, but in type 1 HAE, these patients have decreased C1 esterase. If they don't have it, they don't make it, and whatever they have doesn't work. And they also have a low C4 level just due to the consumption of the complement pathway. In the type 2, which is only 15% of HAE cases, they have normal or increased C1 inhibitor antigen, but they have non-functional C1 inhibitor and low C4s. There are other types of angioedema, the ACE-induced angioedema and idiopathic angioedema, and this form of hereditary angioedema, which has normal complement. Their tests are all normal. There is this acquired angioedema, where they have low C1 inhibitor antigen and function, and low C4, but these patients have antibodies that are directed against C1 inhibitor, and so they actually neutralize the C1 esterase inhibitor, and they can't regulate the production of bradykinin. I mentioned genetic testing is the only definitive way to differentiate HAE patients with a family history and genetic mutation from acquired angioedema, which don't have a family history, and then it can be very confusing. Mediated angioedema that is not caused by hereditary angioedema, or that is caused by hereditary angioedema. We just don't have a way of measuring it. These tests take time. You send it off to a lab, and they take a few days to a week to really get back. So if a patient presents for the first time, we don't know if they have HAE or not. Again, there's a lot of work trying to look at other biomarkers and other ways of measuring activity that would indicate if a patient's having an attack or some other processes going on. Recognize patients with HAE still can have acute abdomens, they can have appendicitis, they can have other conditions, and we have to be aware of that. The goals of management and treatment of these patients is to reduce morbidity and mortality by making an early and accurate diagnosis. Treatment should be individualized to the patient's needs. There are now on-demand treatments and prophylactic treatments. Patients with this condition should be followed by a specialist who is familiar with HAE in their care. And again, optimal care should attempt to restore a normal quality of life in these patients. The categories of treatment are acute on-demand treatment, which will ameliorate the symptoms of an acute angioedema attack. There are patients who get short-term prophylaxis to prevent against a likely attack. This is something we do when patients do go to a dentist and they're going to have a root canal, they're going to have a major dental surgery, depending on their history of attacks during a physical trauma. We'll treat them with a drug 1 hour, 2 hours before the attack, and they'll also, before the procedure, and they'll also bring additional treatment in case after the procedure they start swelling. And then there's also long-term prophylaxis, and this is where people take treatment every 3 to 4 days to prevent the attack. This is a table which shows the prophylactic treatments that are currently approved by the in the United States. And again, we have C1 esterase replacement therapy that's derived from plasma, human plasma. It's filtered, it goes through nanofiltration, so the risk of transmitting infectious organisms is extremely low. In fact, there's never been a reported case. Again, it basically replaces the C1 esterase inhibitor. There is a risk of anaphylaxis, and these patients should receive an epinephrine injectable injection. But these patients can be these patients can self-administer C1 esterase replacement therapy. There's a company that makes C1 esterase replacement for acute attacks. Again, highly purified. It's administered as a dose based on dose basing, 20 units per kilogram, and again is very effective in preventing attacks. Ecallantide, which is Calbitor, it's a kallikrein inhibitor, also is an on-demand therapy. Icatibant, which is a bradykinin 2 receptor blocker, is also on-demand therapy. And there's also recombinant human C1 esterase inhibitor, which is made in derived from rabbit breast milk, and this again also is effective for preventing acute attacks. We've already talked about short-term prophylaxis, but this is certainly something that's used in patients who are expected to receive trauma procedure. We would actually give them a pre-procedural treatment to prevent their attack. Many of these patients will tell you that whether or not they get swelling in response to physical trauma. Again, it's also recommended for emergency procedures in pregnant patients and so forth. There's other on-demand therapies that should always be readily available during these dental procedures or surgical procedures to prevent swelling episodes. So case 4 is a 69-year-old female who presents with recurrent lip and tongue edema initially once every 3 months, but now is occurring on a weekly basis. She has no hives, no known triggers, no prodrome, no family history, and is not taking ACE inhibitors. On evaluation, she has a low C4, she has a low functional C1 inhibitor level, she has a low C1 inhibitor protein level, and her C1q is also low. Further testing revealed that she had an M spike, a serine protein electrophoresis, and on bone marrow biopsy, she was found to have a monoclonal gammopathy of unknown significance. She also had blood sent to a laboratory which showed that she made antibody against C1 esterase inhibitor. So based on all of this evidence, she has what we call acquired angioedema. These patients do not have mutations, genetic mutations in their C1 esterase inhibitor gene. They have either an antibody against C1 esterase inhibitor that would prevent regulation of the contact pathway, or they have a MUGAS, a monoclonal gammopathy of unknown significance, that consumes complement and can cause these reactions. So in acquired angioedema, again, patients have a later onset of action. You can see when we look at the differences between acquired hereditary angioedema to C1 esterase inhibitor, more HAE patients have earlier onset versus patients with acquired have later onset. They both can have abdominal pain, but C1q, which is the first component of the C1QRS complex, is low compared to hereditary angioedema, where it's typically normal. This is much rarer than hereditary angioedema. 1 in 100,000, 1 in 500,000 patients. They have no family history. As I mentioned, they can have the lymphoproliferative disease, they can have the autoantibody, or they can have both, and there's no genetic mutation. This just talks about laboratory testing. It looks just like HAE. Again, the difference is these patients have low C1q in 70% of cases, and they have the antibodies as well. The treatment is to really, if they have the lymphoproliferative disorders, to treat the underlying lymphoproliferative disorder. This doesn't always prevent reoccurrence of angioedema. Plasmapheresis or of anti-IG of these antibodies against C1 esterase inhibitor followed by Cytoxan or rituximab has been effective. On-demand therapy with icatibant or icalantide is appropriate. However, more recently we found that tranexamic acid, which is an antifibrinolytic agent, is extremely effective to prevent angioedema attacks, and this is really considered probably the treatment of choice for acquired angioedema. It's more effective than using other agents such as androgens. C1 esterase inhibitor replacement therapy is not as effective in these cases. So the next case is a 71-year-old male who, with a history of diabetes, high blood pressure, cholesterol, mild renal insufficiency who presents with 1.5-year history of lip and tongue swelling, which occurs every 3 months. No defined triggers, no family history, no relationship to medications, foods, or underlying medical problems. The episodes are responsive to antihistamines until recently. Corticosteroids at high doses appear to be of help, but causes blood glucose to increase. He has no associated hives, difficulty breathing, wheezing, or throat closing. His laboratory testing was unremarkable. His C4 level was normal. His total IG was normal. In subsequent visits, he was prescribed a number of other medications, including Montelukast, which is a leukotriene receptor blocker, also known as Singulair, doxepin, hydroxychloroquine, known as Plaquenil, colchicine, dapsone, sulfasalazine. None of these had effect. We would not put him on immunosuppressives like cyclosporin because of his underlying hypertension and renal insufficiency. He was finally started on omalizumab, which is a monoclonal antibody directed against IgE receptors. And again, his angioedema resolved after the second injection. So this is a classification scheme which we've been talking about of angioedema, and you can see that there are these groups of patients who aren't responsive to antihistamines that are called idiopathic non-histaminergic angioedema. And again, some of these patients who have hereditary, who have normal complement, who have family histories are thought to have hereditary angioedema of unknown origin, but these patients really may be these idiopathic non-histaminergic angioedema cases. So in terms of definition, the idiopathic non-histaminergic angioedema, there's no identified cause by history, no family history, unresponsive to H1 antihistamines, and unresponsive to corticosteroids. The hereditary angioedema, normal complement, they may have a factor 12 mutation, or if there is no mutation, they must have a family history of more than one relative, and they also are unresponsive to antihistamines and corticosteroids. The patients with normal complement hereditary angioedema, again, these are clinical criteria. They get recurrent swelling, absence of urticaria. It's usually circumscribed swelling, so it's in one place. It causes deformity. Duration lasts longer than 24 hours. They get recurrent abdominal pains. Corticosteroids are ineffective, and long-term antihistamines are ineffective. The clinical characteristics do not differentiate between HA normal complement angioedema and idiopathic non-histaminergic angioedema, however. This is just a study showing current treatment options for idiopathic angioedema, and the conclusion here is despite unknown etiology, this article highlights variable treatment options for idiopathic angioedema. More clinical trials and better markers identifying the cause of angioedema are needed. So they tried a number of different things, and none of them were uniformly successful. This is just a study showing tranexamic acid and may be beneficial also for these patients, as some patients with this idiopathic non-histaminergic angioedema responded to this agent as well. So what are the considerations for dental professionals? I apologize for that. Is a medical history taken? Is angioedema listed? If so, probing whether an angioedema attack has ever happened during or after a dental procedure should be done. Is the patient taking an on-demand or prophylactic medication to prevent angioedema attacks? Does the patient have on-demand treatment readily available if they have an angioedema attack, especially hereditary or acquired angioedema? A patient should notify their physician prior to a dental procedure to determine if pre-treatment plan to prevent or control angioedema is warranted. So in summary, Angioedema can be histamine mediated or bradykinin mediated. Other mechanistic pathways may be involved. All patients with isolated angioedema should have a C4 level to exclude bradykinin-mediated angioedema. Again, most of you may never see a case of this, but it is something you should be aware of in your differential when you see your patients and you take your medical history. Patients with angioedema not responsive to antihistamine should be referred to an angioedema specialist for further evaluation and management, and dentists need to be aware of these conditions and have treatment plans in place before proceeding with dental procedures. So I want to also leave you my contact. This is my email, and you're welcome to contact me if you have any questions afterwards, especially if you see patients who have unusual swelling episodes or have a history before you start doing invasive procedures in your offices. With that, I'd like to conclude this talk. Thank you very much, and I'm certainly more than willing to take any questions at this time. If a patient appears to get angioedema while we are working on them, do we give them epinephrine IM? How much do we give? And I think that, yes, this is a good question, and certainly if they don't have a history of hereditary or acquired angioedema and they have swelling, then you should err on the side of commission than omission, and you would give them 0.3 cc's intramuscularly at a concentration of 1 to 1,000 dilution. And this certainly is recommended, and you may also give them some antihistamine as well. And this sometimes can happen. We see a lot of patients who come into our office with suspected drug reactions. Again, local anesthetics rarely cause allergic drug reactions, especially today where we use mostly amides. Used to use these esters derived local anesthetics, and those were much more common, causing allergic reactions. But I don't think those are used that often in the dental practices these days. Can you use EpiPen? Yes, epinephrine. EpiPen is an epinephrine injectable, and this is something that certainly can be used in this situation. If you have a patient who's swelling in your office and you're concerned, and so forth. Again, probably the more likely reason for swelling could be an allergic reaction to something as opposed to the hereditary or acquired angioedema, which are more bradykinin mediated, and epinephrine is more likely to be effective. Now, again, patients might come in on ACE inhibitors and they can also swell, but that's not typically caused by the dental work that they're receiving, so that's something that happens just spontaneously, intermittently. But yes, you can use EpiPen as and that's a standard dose, and it's meant to be given intramuscularly. It already has the pre-dose of 0.3 cc's of 1 to 1,000. There's another one called AviQ, which is another form that actually talks to you. It has it's sort of like those EKG, those cardioversion things where it actually instructs you on what to do when you administer it. Good night. Thank you.